within the year. Cervical cancer remains the leading cause, leading in terms of diagnosis and mortality on the continent. And unfortunately, this is one of the most preventable disease conditions that we should not be talking about now. If we should compare this to other cancers where we don't have proper screening or no established screening, but this, we have the screening. And now even vaccination before the screening. So why are we getting so many of these women coming in? Ovarian cancer we'll talk about shortly. So what is the reality on the ground? Cervical cancer, late presentation, and in cancer management, we need the surgeon, we need the pathologist, we need the radiation oncologist, the medical oncologist, we need palliative care. So it is a lot of human resource that we need when it comes to the management of these cases. The cancer care continuum: prevent, screen and treat, make a diagnosis when there's cancer, and also treat when you have the cancer. And then once we finish with the treatment, we shouldn't say that is the end of it. The patient has survived. But what is beyond that? What is the impact of the cancer on her quality of life? For cervical cancer, as we know, this is due to HPV, highly preventable, and we know the cause, just like we know the cause for malaria. So why are we not there yet? This is a very big question that we ask, and fortunately, we'll be told that several women that are presenting now were born when the vaccines were not available. But then, without the vaccine, we still could have screened. So what happened to the screening? And if we had not screened, what happened when these women even had early stage disease, when we could have prevented that? So these are questions that we need to be asking ourselves. Cytology has been the bone of the prevention of cervical cancer, using the conventional and the liquid-based. Currently, we have the HPV DNA test, which also allows for self-sampling to be done. VIA, that is visual inspection for acetic acid. Acetic acid is the common vinegar that we have in the kitchen. And what prevents us from using this to diagnose pre-malignant conditions of the cervix. And we still use this acetic acid to aid when we're doing colposcopy. So the prevention across the life course: healthy girl, we need to vaccinate. Then we need to screen. We have to make early diagnosis, and then timely treat these conditions, and then the survivorship. The 90-70 targets by the WHO, I'm sure all of us are aware, and I'm happy to say that, yes, Rwanda, we are learning from you. Uganda, Kenya, Tanzania, you are the leaders when it comes to vaccination. Ghana started the vaccination last year, October. So we are not even 1 year. Then we had only 2% of our girls who had been vaccinated. As at then, 2 against 90. Fortunately, we started, and about 83% of women, of girls, were covered at the roll-up. And we are also aiming to get there. Screening 70% of women who are eligible. And here too in Ghana, we had just about 3.6%. It's not going higher. We still need to do some more to reach up to these targets. And then 90% of these patients need to be treated. The opportunity we have here is that, yes, we can still use the school-based vaccination as was done here in Rwanda, and that is what we did in Ghana and continue to be doing. HPV self-sampling, as I mentioned, in terms for the HPV DNA tests, and then the screen and treat approach, which Ghana started but stalled along the lines using the VIA and then the treatment. If we have cervical cancer, what do we do? Early stage, surgery is amenable. Late stage, then we have to go for chemoradiation and also look at the advances in the treatment of cervical cancer now. That is the immunotherapy and also targeted therapy. For cervical cancer, radiotherapy works along all these 4 stages, from stages 1 to 4. But when it comes to surgery, this is limited to the early stage. And of course, we should not forget about palliative care, because our women, the diagnosis is made late. For ovarian cancer, yes, it still remains a big challenge. One, because we say it's a silent killer. It does not give symptoms. And the time the symptoms appear, that is when it's already in the stage 2, stage 3. Unfortunately, there's no recognized screening for ovarian cancers. But yes, this can be done in women who are at very high risk of ovarian cancers, and these could be screened with regular clinical checkups, ultrasound, and other means. So early satiety, bloating, pelvic pain, abdominal distension. When these women come in this already, the disease is advanced. And I will say that this is not only to amongst us, but it's the same presentation globally. Women tend to present late because these symptoms will come in when the disease is advanced. Apart from ultrasound, we use the CT scan, and we also use the biomarkers, especially for the epithelial ovarian cancer, CA125. And we use risk algorithms to help to know which of these women who have agnesa masses are at risk of malignancy. And of course, we have the genetic testing. The treatment for ovarian cancers, surgery. Unfortunately, most women are fit for surgery by the time you see them. Very few are not too fit for surgery, in which case then we say, well, let us go for a new adjuvant chemotherapy to shrink the disease, and then we'll see whether we'll be able to operate. But to make a stage for ovarian cancers, this is what we call the surgical pathological staging, and most patients would need the staging, and it is staging and treatment at the same time. And most of these are very sensitive to the platinum taxane chemotherapy. But currently, we have on the market and in practice the maintenance therapy that may include the PARP inhibitors and then the BEVs. Endometrial cancer, yes, we do see, and is the number 3 when it comes to gynecological cancers. And we are making more of these diagnoses because of the changing times. Our women are becoming more obese. The population is also aging, for which reason we should not lose sight of the fact that the patient who is in the menopause and is having bleeding, we must rule out a cancer before we say, no, this may be a breakthrough bleeding. The postmenopausal woman who is bleeding would need to find out where the bleeding is coming from. If it's not from the vulva, Is it from the vagina? Is it from the cervix? You check all and you don't find where it is coming from. It's coming from up there. We don't have to meet this diagnosis. Vulvar cancer, very much related to cervical cancer, the same HPV, 16, 18, and the rest. In our diagnostic approach, very easy. This is what makes learning in the medical school something that you never forget. Wherever you are stuck and you want to know when to move, you are asked about this, how will you manage a patient? We go through this algorithm, take a comprehensive history, and do a thorough physical examination, and then apply the necessary imaging techniques, pathology, staging, and of course, for the management of cancers, it is not a one-man decision. It should be a multidisciplinary tumor decision. I mentioned the fact that we need the pathologist, and the pathologist also needs information from us to get us the right results. So, from the pathologist, what we expect is to give us a tissue diagnosis, histological subtype, the grade, molecular markers, and then what we say is, if we don't have a histological diagnosis, then we can't treat. What are you going to treat? Imaging in gynae oncologic patients, ultrasound for the first line investigations, CT scan can be also used for the staging and metastatic disease, MRI, local disease extent, PET-CT also in use, also for nodal disease. The MDT team, this list is not exhaustive enough, but depending on the case, you should have a gynae oncologist, radiation medical oncologist, pathologist, radiologist, oncology nurse, and of course, palliative care. And we need the palliative care not only when the patient has come with advanced disease. Palliative care must be instituted at the time of diagnosis, irrespective of the stage. The principles of surgical management for gynae cancers, the aims of surgery is to first obtain the diagnosis, and it could be just a biopsy or doing the surgery itself to stage the disease and also achieve complete tumor removal. And this surgery could be open, could be laparoscopic, or could be robotic. For the cervical cancers early stage, what we do is a radical hysterectomy for ovarian cytoreductive surgery. For the vulva, we do a vulvectomy, and also we do sentinel lymph nodes. Medical oncology, chemotherapy, the targeted immunotherapy, antibody drug conjugates, and also clinical trials. Molecular oncology, these are emerging paradigms. Now, ovarian cancer doing the BRCA testing, and also homologous recombination deficiency. But this actually alerts us as to which of these ovarian cancers will be chemosensitive to the platinum-taxane combo. Endometrial cancer, now we have molecular classification. For the cervix, we still can do the immunotherapy biomarkers. Radiation could be given by external beam or the intracavitary, that is a brachytherapy. And there are various ways of making sure that the targeted therapy is to the tumor so as to spare normal tissues and also reduce toxicity. And these are the adaptive brachy and then the image-guided radiotherapy. Systemic therapy, chemo, targeted immunotherapy, Then also have hormonal therapy. As I mentioned, once we finish the treatment, that's not the end. The patient needs, we also need to address the patient's sexual health, her fertility, menopause issues, mental health, and of course, also do about the quality of life. What are the challenges in Africa? Workforce shortages, the limitations in funding is across board. We still have infrastructure gaps, diagnostic delays, and also limited radiotherapy centers. And when it comes to cervical cancer treatment, then we need the radiation therapy. And we need all these to be spread so as to enhance the treatment for our patients. Do we have opportunities? Yes, we do. We can now go on regional collaboration, have cancer registries, which is almost absent in most of the countries. And we can now, with the technology, use telepathology, artificial intelligence, HPV vaccination, and also look at tax sharing, especially where we talk about reduced workforce, we can use other healthcare workers. The vision for Africa is for the healthy girls, vaccinated, educated, and screened. Healthy women, we have to diagnose early, treat effectively, and also support them through the survivorship. Healthy nation, strong families, productive workforce. What must we do? We must invest in girls, continue with the vaccination, improve on the primary health care, universal health coverage, cancer centers, do research, and also workforce development. Every girl deserves HPV vaccination. Every woman deserves access to screening. Every patient deserves timely diagnosis. Every nation deserves equitable cancer care. Together, we can change the future of women's cancers in Africa. Healthy girls plus healthy women will give us a thriving nation. I thank you very much.
Thank you, Professor Kony. I think, Professor Kony, please take your seat here. So he's going to be part of our panel discussion. So if you have any questions for him, we shall have some time to direct our questions to him. So our next, we shall jump directly into our next panel. And our discussion is around the current status of gynecologic malignancies in Rwanda. We shall go through the approaches right through the management. And this is an important topic because currently these cancers remain an important cause of morbidity and mortality among women in Rwanda. And where we have made very significant progress, as some of our professor was talking about, particularly in cervical cancer screening and prevention and the development of our services in Rwanda, we continue to face very important challenges. So today this panel is particularly very, very important and very close to my heart. And so I'm very, very honored to welcome these panelists who are going to continue our discussion today. Allow me to welcome, I'm very honored to welcome Dr. Theoneste Maniragawa. Dr. Theoneste Maniragawa, I'm very honored to welcome you. I'm particularly happy to introduce him, not because he's not only an excellent oncologist, but he's also my friend. So, but apart from that, he's a consultant clinical radiation oncologist. and most importantly, the Director of Cancer Programs at the Rwanda Biomedical Center. He also, with all that, he still practices at Rwanda Military Teaching Hospital, and he's trained as a clinical and radiation oncologist. He focuses particularly on breast and cervical cancer, and beyond that impressive, as I mentioned, a very close friend of mine. So, I'm very honored to have you, and please join me in welcoming him. Our next panel today, we are also very honored to have someone who needs very little introduction, Dr. Blaise Dushimimana. Dr. Blaise is he's a gynecologist oncologist at faculty at the University of Rwanda. He's one of the pioneers. He's one of the pioneers of gynecological oncology in Rwanda and has played a very important role in the development of the specialty. I also say that now mark this, he's a very highly skilled pelvic surgeon. And his surgical, this is one of the people you want standing next to you in theater if you have a difficult case. So beyond his surgical skills, he's one of our pioneer gynecological oncologists. Dr. Blaise, we are very honored to have you. Our next is going to bring us a perspective that oncology needs. Dr. Patrick Chizubo. I hope I pronounced your name well. He's one of our very own. He's a senior consultant radiologist and is based at Kigali University Teaching Hospital. And he's a trained diagnostic radiology, and areas of interest include oncologic imaging and non-vascular intervention radiology. Today he joins us to provide the radiology perspective, and we are very honored to have you. Please join me in welcoming Dr. Patrick. And last but certainly not the least, I am particularly pleased to welcome on stage our only woman on the panel. Our only woman in the panel, okay? Dr. Linda Adetus Kapesa. Yes, yeah, she deserves a big hand clap. So, she's a medical oncologist and brings more than 10 years of experience in the management of solid and hematologic malignancies across sub-Saharan Africa. She worked at Muhimbili Hospital in Tanzania, and currently she works with Partners in Health and Butaro Cancer Center of Excellence, where she provides care in limited resource settings, and she's also adjunct lecturer at the University of Global Health Equity. Welcome, Dr. Linda Kapesa. So today we are very happy to have you and welcome you as a panelist. So this panel is particularly very, very interesting, and I'm honored to be moderating this this panel. Thank you so much for honoring our invitation, and I'll just kick off our discussions with Dr. Theonest. Dr. Theonest is not only a clinician but also a policymaker, so I think it makes sense to start off the conversation with him. Dr. Theonest, given your work at the Rwanda Biomedical, the Rwanda Biomedical Center, you know, from the national policy perspective, where are we today in Rwanda? Where are we today in terms of the burden of gynecological malignancies? And I want you to take us through the priorities as government of Rwanda in the next 3 to 5 years in terms of gynecologic malignancies.
Thank you, Dr. Kenneth, and good afternoon, everybody. And I'm very grateful to RSOG, first of all, for your honoring our good partnership, first of all, with RSOG. But also, I am grateful to you for inviting me personally and our program. So RSOG is playing in supporting the program to make sure that the cervical cancer elimination for Rwanda, which is Mission 27, can be achieved. Very grateful as the president is here. So, this is the first Rwandan organization that is supporting. Others also are here. I think others ranks number 1. And then, what you have to remind me, there are like 3 key facts. One is that the numbers of all the cancer detection that we are getting have been multiplied for by 10 folds since the last 10 years. This means for the last 10 years, if we were having in our cancer registry 700 cases, now we are getting 70,000. And among all these 70,000, 10% cancers. Women cancers, this means I am not counting breast cancer, because actually breast cancer, people tend to confuse that it is only for women, while it is for women and male. Male, make 3% of breast cancers. That's why when for those people who are consulting our registry, in even the group of CAN, that in Rwanda, the breast cancer ranks number 1 when you add up female, male. But when now you rank cancers, comparing male to females, cervical cancer comes number 1. I want to make this clear. So within female cancers now, cervical cancer also still ranks number 1, followed by ovarian cancers, and then uterine cancers following. I can't repeat about the risk factors. They are quite the same in low and middle income countries, even globally. And Professor is here, he has been giving a very good lecture. So for us now, the burden for the last year, if I give you numbers, we have found around 788 cases of gynecological cancers. Around them, 586, they were cervical cancers. And then ovarian cancers, they were 128, followed with some 20s of uterine and vulva and others. So to show you the picture that cervical cancer is a burden. The presentation, staging, all professors mentioned. So for us now, if you add up with breast cancer and prostate cancer, all 3, they will make 30% of our entire national burden. So most of our effort in the program is to make sure that we develop strategy, to make sure that we promote all promotional activities to make sure that cervical cancer, breast cancer, prostate cancer are tackled in education, screening, availing treatment modalities, navigation, of course, availing treatment commodities. So going to cervical cancer now. Mission 27 was elaborated in 2024. For that, the first pillar of vaccination that was started in 2012 has been maintained at 93. There have been a fall down in 2020 because of COVID. As all of us, you know that our vaccination routine goes through the school. And because of COVID, most, the school presentation dropped out. We couldn't achieve the 93, but at least we could maintain the WHO required, targets, which is good. Now, what we are doing, where we are falling short at around 93, we are now in another program to make sure that we catch up for those 7 that have missed in what we are calling accelerated cervical cancer elimination. We have started it in Karongi, Kayonza, Gicumbi, and Nyarugenge. So if you are following now, all these ladies that disappeared or that couldn't have the vaccination, we are vaccinating them. Following also the ladies have not got, who have not got the screening. The second pillar on screening, that's where we have to, a very big challenge, because it is a very robust program that requires to screen all women of age of 49 years. We are now turning to 37. In last 2 months, we were at 36. Now we are at 38 because Rwamagana is joining the map. So in 3 months, we want to make sure that the entire Eastern Province will be green, achieve the target, turning to be north because by next 3 months, we want to make sure that Gatsibo, Musanze, Burera are turned also green. The remaining challenge will be in Western and South. And remember, we are remaining with 14 months to achieve our mission because the mission is 2027. Rwanda has committed to achieve this mission 3 years before WHO targets. The third pillar is about treatment. We have maintained the treatment for precancerous lesion around 90%. The challenge is about treatment for malignancy. And diagnosis is very good because we have in all cancer treatment centers, south, north, in Kigali, we have all treatment modality, diagnostic modality. I'm talking about pathology and imaging. Now our teaching hospitals, Seashibe, Seashika, Kanombe, they have MRI, which is the best staging tool that we need, or available. So it's about radiotherapy because when you bring cervical cancer patient, 70% of them, they will need radiotherapy. And you have long waiting time. That's why we are now, within these 2 months, working with the Ministry of Health to make sure that we did by, we are working on a project to bring radiotherapy in Butare and Butaro so that at least the numbers can, going to RMH can decrease. IAEA standards requires that for a million population, we have to have 1 machine of radiotherapy. We have only 2 machines in a population turning to be 15 million, so we need to increase our machine to 15. So we are hoping that when we get these 2 machines, we'll be having 6 machines, and it will be, by the way, a very good number if you compare with our region. Because, for example, Tanzania, sorry, Linda. Okay, I don't want to mention the numbers, but I love to speak about Tanzania because it is a country that educated me. It is my second home. Thank you for being here. So there is an issue of equity and equality and access to radiotherapy. So that's the myth that government of Rwanda want to remove because we think not only about even Rwanda, about surrounding countries because they are consulting us. But also we have also to add the treatment modality and follow-up modalities. About functional imaging, we missed PET scan that we're going to search in surrounding region, especially Kenya, India, and Europe. We are having a PET CT, of course, with the cyclotron in the coming 2 months. It is about to be finished in RMH. So that's where we are. And we think with the very good political will, of course, we have to work together with all our partners. We'll be there. Thank you so much.
Thank you, Dr. Honest. I'll just direct my next questions to Dr. Blaise, and he will give us a clinical perspective. What are you seeing at the tertiary hospitals? Do they reflect the national picture? I mean, Dr. Theonest has talked about some of the gynecologic malignancies. So what are the major malignancies that you're seeing? And which are the patients generally presenting? Are we seeing a meaningful shift to earlier stage disease, or are most patients still presenting with advanced disease? What's your experience, Dr. Blaise?
Thank you very much, Dr. Kenneth. Thank you for the good question. So I thank Dr. Theonest and Prof. I think most of the things Professor said from Ghana, it looks like the same in our settings. So I'm glad that we are now talking about all gynecological cancers. In our previous meetings, we used only to focus on cervical cancer, but I can tell you that gynecological cancers now, so all of them, they are there. So every day we see cervical cancer, we see ovarian cancer, we see endometrial cancer, vulvar cancer is not much, we see GTN, so all those are gynecological cancers that we are seeing. So the common one that we see, it's like all MIS, in all MIS, I think cervical cancer, we know that it's the most common. And unfortunately, most of the people that we are seeing, they are coming in late stages that are no longer operable. So that require chemoradiation, and as Dr. Tiones is saying, which is limited. So that is our findings during our clinical activities. So what I wanted to bring today is that it's not cervical cancer that is only existing in gynecological cancers. We are also having other cancers, and which are concerning and which are presenting in late stages. Thank you.
Thank you, Dr. Blaise. I want to just bring in another perspective, which is very important in gynecologic malignancy, and I will direct it to Dr. Patrick. I mean, with one of the most senior radiologists we have in the country, I just want to find out from you concerning the use of imaging in Rwanda currently. Has the availability and the use of imaging changed the management of gynecologic cancers in Rwanda? Generally, take us through your experience around that.
Thank you, Dr. Kenneth, for having me. Yeah, definitely there is a significant change in how we approach gynecologic malignancy in Rwanda. From identifying a tumor, now we are able to characterize the disease and its extent, to assess for lymph node involvement and distant metastases, to stage the patient, to help guide the treatment, to assess post-treatment response, as well as post-treatment surveillance. So all in all, it's that radiology is integrated now within the patient cancer pathway, responding to the clinical question requested by the referring clinician.
Thank you so much, Dr. Patrick. I want to just make the discussion wider, and I want to first of all apologize for my oversight. I think I'll take the blame for this. And if you apologize that we had one panelist who should be here, and I didn't introduce him, so I want to apologize particularly to him. One of a very close friend of mine as well, Professor Mandachiza Felix. And I want to direct, please, Felix, can you just please come up? Because the next question is directed to him. And I want to apologize that I did introduce him. I hope you find a place in your heart to forgive me. I'm very sorry. Yes, thank you. So I'm going to direct the next question to him, and he's going to take my spot to answer it. Professor Felix. Professor Felix is Associate Professor of Anatomic Pathology and Molecular Pathology at Kigali University Teaching Hospital, and he's also Associate Professor of Pathology at the University of Rwanda. And he has contributed as well to a lot in terms of cancer care as one of our senior histologists. So my question is going to be directed particularly to him. And one of the biggest problems that we struggle in cancer treatment is diagnosis. So I'm going to ask him, given his vast experience regarding this, should we trust the diagnosis? How can we trust the diagnosis? how confident are we currently in the pathologic diagnosis and classification of gynecologic malignancies in Rwanda? Professor Felix, please accept our apologies, and I hope you can be able to answer these questions. Thank you so much.
Thank you very much, Dr. Kenneth. Good afternoon, everyone. And thank you very much for inviting me in this discussion. And then what I can say about this question, asking how confident are about the diagnosis, histological diagnosis. I can say that our confidence is moderate and but improving. And then I will be explaining. Just is moderate because for histopathological diagnosis, there are some diagnoses which are straightforward, so easy to make diagnoses. And for some cases, we need additional or ancillary tests, including immunohistochemical staining, which are not very commonly done in African setting. And when we go also to molecular testing, we are still lagging behind. So for challenging cases, for complex cases, our confidence is still low compared to very frequent cases which are very easy to make the diagnosis. So then I can say that with lack of these immunohistochemical confirmation, some cases are lacking. And then the other issue is, as you know, in medicine, we have specialty and subspecialty. Currently here in Rwanda, we don't have any gynecological subspecialty in pathology. So we need to, sometimes we need a second opinion from other people. So we are working with people from other countries in those very cases to get the input, and then to try to improve the confidence in the diagnosis. The other thing that I have to say is, again, you know, when you are dealing with cancer management, we have multidisciplinary team. Sometimes we need also, again, to be collaborating with the treating physician to say, I was expecting this, and then you are reporting this, where the problem could be. Because, again, when you are saying cancer diagnosis using histopathological tools, we may have, for example, a bigger cancer, a bigger mass. And then we just will not be using the entire mass. We'll be sampling part of that mass. And then, as you know, the cancer is heterogeneous. So in this case, we need this collaboration with other medical personnel just to discuss about what we provide as a diagnosis and what they were expecting as the diagnosis. This is what I can say about our level of confidence.
Thank you so much, Dr. Felix. Please take your seat. I think you realize that if we hadn't had him, we would have missed a very important perspective from Professor Felix. Thank you so much for that. And I'll direct my next question to Dr. Linda Kapesa. From the medical oncology perspective. I know Butaro Cancer Center for many years has been the only cancer treatment center that we have had in Rwanda, and Dr. Kapesa has been very instrumental in the functioning of the center. So we just want to listen from her, or from the medical perspective, how has systemic treatment of gyn cancers evolved in Rwanda, and take us through, like, realistically, what treatments are currently accessible for our patients in Rwanda. Dr. Linda.
Thank you, Doctor, for a very good question. It's a very good question, a bit long, but I'll take you back through the history. So it all started in 2012, where oncology capacity in Rwanda was very limited. And an NGO, an international NGO called PIH, or Partners in Health, decided to come to Rwanda and provide cancer care in collaboration with the Ministry of Health and the government of Rwanda. So by then, when this international organization came to Rwanda, they didn't have a gynecologist, they didn't have oncologists, they didn't even have like any specialist at the time. So they only relied on MDs, the general MDs, the registered nurses, and they formulated some kind of protocols, and they were mentoring that was happening at the time, and experts were also around. So what So what was happening is these healthcare workers, the registered nurses, the MDs, they are using these formulated protocols which were evidence-based. At the time also staging was so hard, they were relying on only ultrasound, and since there was no gynecologist, they used to send some patients to Kigali, I think, for physical exam, and that was it. So, for the biopsies, they used to send some biopsies to Boston. Between 2014 and 2016, that was when Partners in Health, which is based in Butaro at the lower limited setting area, they got one pathologist which was hired by the Ministry of Health permanently. So after that time, then they started producing immunohistochemistries, and then around that time as well, even gynecological surgeries, I think locally in Rwanda, they started happening through the system called Resource of Health Program, which was supported by PEPFAR. Staging was quite hard at the time. And then in 2018, that was when they were able to hire one specialist, which was an internist, but he had 1 year training of medical oncology. So they kept on treating these cancers, like the type of cancers that they were treating was cervical cancer, ovarian cancer, the GTN, the germ cell tumors, and endometrial cancers. But some of the, before I forget, let me take cervical cancer for an example. So at the time when PIH came to Rwanda, for patients with early cervical cancers, we are receiving radical hysterectomy and then just follow-up. But for patients with locally advanced cervical cancers, they are referred to Uganda and Kenya for radiation therapy. So it kept on going like that until 2018, when they hired this doctor with an experience, 1 year training experience of medical oncology. They continued treating, and luckily in 2019, that was when RMH, which is Rwanda Military Hospital, opened the cancer center. And at the time, that was when PIH stopped sending patients to Uganda and Nairobi, and all these patients started getting treatment here in Rwanda. So since then until now, there's been a lot of advancement. Right now, we are treating almost all the cancers. We are using combination traditional chemotherapies, like Professor Thomas said. We are using, we have a couple of medications, like the combination of platinums, like the carboplatin, cisplatin, detaxanes, paclitaxel, docetaxel. Also for some cancers like the GTN, we have, before we used to have, like for low risk GTN, as we know, they are treated with oral methotrexate, but right now we have advanced even for refractory disease for patients who are receiving, let's say, Omako and the resisted. Now we even have second lines, we're giving regimens like MIP, TPTE. So we have advanced so much right now. And luckily, before June this year, even the Rwandan government have decentralized cancer services to other hospitals, not only in Butaro. So right now, patients can get cancer services even in Sehashibe. Right now, Butaro, of course, which is the Butaro Cancer Center of Excellency, and RMH, and some patients can get the cancer services at private hospital at King Faisal. The challenge that we have in medical oncology right now is just that there's a limited availability of targeted drugs when it comes to treating advanced cancers, like, let's say, cervical cancer. If you want to top up things like bevacizumab, or in maintenance in ovarian cancer, or even this medication like checkpoint inhibitors like pembrolizumab, there's a limited access to those drugs. But confidently right now, I can say that we have advanced so much. In Rwanda right now, we are able, we work in the multidisciplinary team. We have gyno-oncologists. Of course, there are not many, but at least they are there. Gynecologists. There are oncologists everywhere in Butaro and almost in the few other referral hospitals. We have imagings right now that we are sure that we are confident that we can stage. We have, we have the whole team to work together. So I think that is good so far. Thank you.
Thank you so much, Dr. Linda. So I'll just do one round of, final, I'll call it rapid fire question for all our panelists before we end this. And I'll start with Dr. Theonis. In just one word, if you could change one thing in Rwanda's gynecology cancer care pathway tomorrow, what would it be?
Screening.
Thank you. So he's spoken as a policy maker, and I will direct the same question to Dr. Blaise. What is one thing that you think in a few seconds, just 1 minute, what is one thing you think you'd love to change in pathway for cancer treatment in Rwanda?
So I will not say cancer treatment, but awareness of gynecological cancers among patients, among women, let me say women, even before they become patients, and also among doctors who take care of those patients, who are not oncologists. Just they should be aware of alarming signs and symptoms for those patients.
Mm. Thank you. Dr. Patrick, this one is particularly for you. I know you see lots of patients who are referred to your clinic. What are the most common inappropriate, I use the word inappropriate, imaging requests or misconceptions that you encounter from clinicians, especially around gynecology cancer?
Thank you for the question. I wouldn't really want to call it inappropriate because it's from colleagues. I will choose to say that those are opportunity to improve image request or image requesting. So I will go through four of them that we encounter during our daily routine or practice. One of them, I think everyone here will agree with me, requesting examination without clinical information. So we need to know that the choice of the protocol examination, the quality of the imaging, and the quality of the report will depend on the clinical information provided. So the second one will be multiplication of examination on a patient. So we get sometimes the same patient undergone abdominal pelvic ultrasound, abdominal pelvic CT scan, abdominal pelvic MRI. Same result normal, but nothing has changed into the patient management. So here is still back to the clinical information and the discussion with the radiology team in choosing the appropriate examination which should respond to the clinical question that the clinician would like to answer. The third one, I think, will be, it's true now we have MRI, but we have started seeing it. Also when we had CT, it was everything suspected with pelvic was CT pelvic examination. When we know that we have ultrasound and now we have MRI, which those two have better characterization or resolution for pelvic organ compared to CT scan. And the last one, maybe Prof will agree with me. Thinking that MRI now is a substitute for histopathology. So it's true imaging suggests or suspects malignancy, but it's histopathology, which is what we call the Supreme Court of Medicine, which decide or tell us that this is a malignancy or not.
Thank you, Dr. Patrick. So give your microphone to Dr. Felix. I know you've spoken of so many challenges that you're facing in pathology. Again, I'll direct you the question that I directed to your panelists. What if one of the big minds in pathology in Rwanda, what do you think should we do to improve our pathology services, and just one thing that you want to change, for the better of pathology?
Thank you for this question. Just as you said one thing, and I may say, just to have also to increase confidence in the diagnosis, I think the one thing that we can do is enforcing or establishing synoptic reporting, because this synoptic reporting is where people are giving almost all required information. Otherwise, if we are still using free text, free words, we sometimes are not giving what we are able to give.
Break that down, sorry. What is synoptic reporting?
Synoptic reporting
Use the layman's language.
Yeah, just synoptic reporting, I can say, is a template where you have required elements that will be reporting. If you are having those templates, every element is there. Is like a guidance for the pathologists. Because for the cancer diagnosis, just is not a single word, is not two words. It is many information that you have to report. As we saw in the presentation of the professor, you have to give the grade, you have to give the stage, you have to give this, the type, the subtype, and so on and so on. So all those information are a lot of information. So if we are not having something that is helping people to remember everything that should be included there, then we'll be giving a diagnosis that are not complete.
Thank you so much, Dr. Felix. And I'll direct the same question to Dr. Linda. Given the medical oncology pathway and how far we have come, what do you think what should we do, to leap forward in terms of medical management of gynecologic tumors?
Well, I would focus mainly on a multidisciplinary team. I'll make sure that no doctor is supposed to make decisions by him or herself. She should involve the entire team, and the decision should be evidence-based and realistic for the setting. Yeah. So multidisciplinary team is very important when it comes to cancer treatment and management.
Yes.
Thank you.
Thank you. Yeah, go ahead.
Today I'm not talking about clinics, I'm talking about policy. There is something that I want to clear so that my colleagues here working in the clinics, they get tangible information from the policy perspective. So she was mentioning about the challenge about access to treatment. Some treatment modalities. I know, I understand, we agree with what, because both of us, we are oncologists. I'm a clinical and radiation oncologist, a medical oncologist. So cancer treatment requires 3 modalities at least. Local, composed, when we talk about local treatment, is surgery and radiotherapy, and then the systemic treatment. So systemic treatment, there are 2 categories. There are cytotoxics and targeted therapies, including immunotherapy that you have to do after molecular therapy. So the government of Rwanda has approved the cancer treatment under CBHI. But this cancer treatment was not exhaustive. It was approved following the cost-effectiveness studies. Those are health economic studies that we do, checking about the outcome, treatment modality, and then the budget impact assessment. So what we have been approving, it was divided in 3 categories. There is what we call the basic, the core, and enhanced. So Rwandese have been allowed the core treatment modality, which gives the basic minimum at least 80% of treatment, and this goes to what we expect in our settings and available funding. However, this is not static. As the government keeps improving in terms of our health system, as the government, as the health system keeps improving in terms of how we are managing our patients, but also how the economy is, we will be reviewing it. Currently, there is a review of some list of medicine that were not put on the list. I am sure here there are doctors, some of us who have been complaining about, we are reviewing, and I'm sure some medicine also will be added up. But you have to agree with me that in our settings, there are some medicine we want directly approved because, first of all, affordability is an issue, but also diagnostic, molecular testing is not available, and also some dispensing capabilities. So that's what we have, and I think also as we are improving, she has mentioned the history of how cancer care has been improving. I think in 5-10 years we'll reach there. Thank you so much.
Thank you, Doctor. I'll give my last question to Professor Kony. I think, given all these challenges that we face in the management of gynecology cancers, and as somebody who's very respectable in this field with your experience, I just want to ask you, how do you ensure that our patients benefit, from the advances in oncology, but while avoiding a situation where international guidelines and recommendations of treatment are simply not accessible here or sustainable in our settings? How do you ensure that patients benefit, from these advances? I know this is a difficult question, but I know you're the right person to answer this question. How do you ensure that our patients benefit from these advances while avoiding a situation where these guidelines recommend treatments that are simply not, accessible or sustainable in our settings? And that will be our last question for you.
All right, thank you very much. I'd like to start it from where I see my patients. What can be done for them now? And then I look at for them if resources were available. Unfortunately, what can be done for them now, we are not doing to the best of our abilities. And I always say that the best practice in this world is medicine. When we go through the system of history, examination, investigation, and treatment, things fall in place. It's not every bleeding that the perimenopausal woman has which is normal. We say it's abnormal. Prove that it is normal before you continue or leave that patient. The second thing is vaginal discharge. It's not every vaginal discharge which is candidiasis. Examine the woman and see what that discharge is. And you'll be surprised to see what the cause of that discharge is. Not every swelling is normal. That swelling could be on the vulva, it could be in the abdomen. Examine. Get the characteristics of that swelling. If you are not making any headway, the radiologist is there. They will do the ultrasound. And don't hide information from the one who is going to help you manage the patient. Give every information that you have to the radiologist, to the sonographer, to the pathologist. You've done CA125 on a patient with an abdominal mass. You have done surgery for this patient. You know there's CA125 levels. You give the specimen to the pathologist, nothing, only the age. And then you expect him to work magic. Meanwhile, you have CA125 levels, which are in the tens of thousands. And then he brings a report, and you are angry. He says it's not good. But I need a second opinion, and we don't have so many pathologists. Where are you going to look for that patient, for that pathologist? So if we do things systematically as we have been expected to be doing, things will fall in place. And then we'll be able to use the available resources. Once we're able to use these available resources, in fact, most patients will benefit from the available resources. Very few patients will actually require what we are looking for in the advances. If you're able to take care of them very early, they wouldn't need the bevacizumab. They wouldn't even need the PARP inhibitors. Because we've caught the disease early and we have prevented it. If we don't, we're already not there. And they are not available. Then we say, what else can we do? Palliative care. We don't have to get there. Thank you.
Thank you so much. Thank you so much for our panelists. It was a pleasure moderating this panel of eminent experts in this field. We are very honored to have you. Thank you so much for sharing your knowledge and expertise. I would like to request you to give them a big hand clap as they go back to your sets. Over to you.
Thank you
so
very much. I hope without asking they need a much louder applause, really. So there's a lot that was said. So many lectures were broken down, and the presentation and the panel discussions were very rich. So I have to appreciate that as a country, I've noticed from the presentations and discussions that we're coming from way far, and we are on a very present level now, and we hope for the best, as they say, that we will reach there. Thank you very much. So there's someone that had lost car keys. I don't know if they got it. If there's someone who's lost their konache, their car key, then there's someone who picked it. There. Okay, thank you. So next forward, I will come Ariela, Dr. Ariela, to take us through the next sessions. I hope we catch up with time.
Thank you very much, Francis. Our next session is about, it's a state of art. It's about mifepristone use. And we are going to welcome our prof. He's a professor of Obs and Gyn at the University of Zambia, and he's an obstetrician, gynecologist, epidemiologist with extensive experience in clinical research and medical education. Please join me in welcoming Prof. Bellington Vualika.
So good. Is it evening already or not yet? Looks like it was a long day. So I feel honored to stand before all of you. Thanks to RSOG for inviting me to give this talk. My only wish is that after the presentation, people could have options of how they do other medical treatments. So, mifepristone, also known as the RU486, is a drug that was developed in the 1980s when scientists were looking for blockers of certain hormones, in particular glucocorticoids. And in a French laboratory, people discovered that one of the blockers they found could actually block progesterone. And we know that progesterone is the hormone that keeps a pregnancy. So this revolutionized the usage of this drug. And unfortunately, the one who discovered it died just last year, May, so rest wherever it is. So it is typically used in combination with misoprostol to terminate early pregnancies, especially in the first 10 weeks of gestation age. Now, its primary effect, as I've indicated, it blocks the effects of progesterone, and also it sensitizes the response of the uterus to start contracting. So what are some of the approved uses of this mifepristone? The first one is for termination of pregnancy, at least up to 10 weeks gestational age, management of miscarriage, missed abortion, per se, and also it is used as off-label in treatment of Cushing's syndrome. It reduces the cortisols and therefore normalizes the sugar levels in such patients. Now, what is the efficacy of this mifepristone? Because we know that you can also evacuate the uterus using surgical means such as the suction curettage. So the success rate ranges from 95 to 98%, compared to suction are almost reaching the same levels. The only benefit for using surgical means is that it requires fewer follow-up interventions. Now, why I'm discussing mifepristone as an alternative to some managements that we'll soon see is that it's one of those drugs really where there are predictable and few side effects. And therefore it is a drug that we should domesticate in our practices. The common side effects include cramping, nausea, vaginal bleeding, diarrhea to some extent, dizziness, headache, fever, chills, or fatigue. So these are the most predictable symptoms which are known. And in clinical use, it has almost been found to be very, very safe. But then we have consideration for some known, also contraindications, and these could be adrenal issues and long-term use of corticosteroids, bleeding risks, and inherited porphyria. Now, what are some of the regulatory issues? This drug, much as it's friendly, it may not be readily available in certain circumstances. So while approval has been achieved in almost over 100 countries, as a drug for medical abortion, availability really depends on the local legal frameworks, national medicine lists, and also intense political and social stigma. To start with, the people we use as a reference, the US, it was approved by the FDA in 2000, but you know the politics that exist in the US with regard to termination of pregnancy, it depends on who is in power, whether it's the Democrats or Republicans, and also certain states where this is practiced. And yet when it was approved, it was even made accessible through telemedicine. So this drug was first approved where it was developed in Europe, to start with in France in 1988. In low and middle income countries, we still maintain restrictive laws that were left to us by our colonial masters. And where there are restrictive laws on abortion, such drugs are not even permitted. We include countries such as Malawi, Sierra Leone, Liberia. But then if you travel to these places, you find that these drugs are there. And with the social media now, you can actually order the drugs and they will come to you despite the law barring presence of such drugs. Now, what about usage of mifepristone in clinical practice? I'll start with uterine fibroids. By blocking progesterone receptors, mifepristone can reduce the effects of progesterone on the uterine muscle, the lining, and potentially leading to a decrease in cell proliferation within the fibroid tissue. And therefore, we can say in a way this becomes an alternative to using expensive drugs such as GnRH analogs. You can actually reduce the size of the uterus to a size that you are happy to operate on, such as those of us who are doing open surgery, hysterectomy, for example. There will be symptomatic relief in women who are having heavy periods due to fibroids, women who are having pelvic pain due to fibroids, and so the dosages actually differ as well. You can start with low dosages. For example, these women could be taking this mifepristone 10 milligrams every day or 50 milligrams weekly. And usually it takes about 3 months before you start having a clinical effect such as this reduction in the size of the fibroid mass. Another potential clinical practice use is in cases of endometriosis. Again, the progesterone antagonism is associated with reduction in the inflammation. These women with endometriosis experience severe pain, and this is because of this inflammation. And the mifepristone reduces the inflammatory factors. It also reduces the estradiol levels. We probably remember that endometriosis is the proliferation of this tissue as found in the endometrium but elsewhere. And therefore it responds to the stimulatory hormones such as estrogen and also progesterone. So by reducing the estradiol level, we are reducing the hormone that stimulates the growth, and therefore the endometrial tissue will not be proliferating. The mifepristone also inhibits or causes a reduction in angiogenesis. Again, if we look at the pathology of this endometriotic tissue, there is a lot of vascularization. And therefore, if we reduce the blood vessels, we are going to reduce its effects such as growth or the inflammatory reaction, and therefore symptomatic relief will occur. The mifepristone also causes a reversal of endometrial hyperplasia. Okay, so in other words, it may help reverse hyperplastic changes in the endometrial tissue as occur in endometriosis. And therefore, can say patients with endometriosis who experience this debilitating pain, which will be symptomatically relieved if they have this course of mifepristone. So that is why I said you might want to think of alternatives to the conventional hormones as we are treating these patients, as occurs in somebody who has endometriosis We use drugs such as danazol, which has anabolic effects. So you might just consider this benign drug called mifepristone. Now, there is a sticking issue here with regard to medical management of unruptured ectopic pregnancy. We know that the standard treatment, there is a criteria, of course, I don't need to tell the converted things such as the size, no fluid, a stable patient. And the standard treatment for treatment of unruptured ectopic tubal pregnancy is methotrexate, because it inhibits the proliferation of cells and literally killing it. Now, some people have become inquisitive that methotrexate has got a lot of side effects. There's need for follow-up, and so they want to see alternatives which can be of less side effects. So there's a big European trial which is looking at comparing treating patients with methotrexate alone, and another group has a combination of mifepristone and letrozole. Letrozole is an inhibitor of formation of estrogens from male hormones, from testosterone, for example. And so they are trying to find a safer and non-surgical alternative with fewer side effects. So this trial is ongoing, and they are recruiting in some centers in Europe. And from the DSMB, Data Safety Monitoring Board, results so far indicate that the results are almost the same. So we maybe have to wait and see what this clinical trial is going to direct us to. I've already indicated that methotrexate, people want to avoid it because of side effects, and therefore the alternative could be the combination of mifepristone and letrozole. Now, another use of mifepristone that is potentially on the market is the use of it as a contragestive. So those of you who didn't know a new word today, you can use this word, contragestive. It simply means that a substance or device that prevents pregnancy, and it acts after fertilization. I don't know whether people are trying to avoid the word determination, so came up with a benign word of contragestive. So, why this is exciting is that if you look at the definitions, a period is considered to be delayed if it does not come 5 days after it was expected. A period is considered missed when it has not occurred 6 weeks from the last time somebody had and were expecting. Now, pregnancy is the most common cause of a missed period. We know that, but there are other causes. There are times when there are limitations to confirm a pregnancy, and this is done by doing a pregnancy test. And sometimes our people we deal with can actually not afford to pay for a pregnancy test. Another dilemma, I don't know how many of you have come across it, but there are some people who would want to come to you, doctor, I've missed my period. I want it back. I don't want to do a test. Okay? I have to give you similar practices many years ago when I was a junior doctor. By the way, I retired as a medical doctor. So those days, we didn't have things like manual vacuum aspirations. We didn't have mifepristone. You just find that your consultant is pushing you to go and do a DNC, but they used to call it menstrual regulation. So you are there in theater, you are surprised, a lot of products are coming out. So in reality, that woman could have been pregnant, and the consultant has sent you to do a termination by dilatation and evacuation. So I don't know whether that term is still being used, menstrual regulation. Okay? But then, mifepristone is considered as one drug that can be used to bring back these periods. And yet, you know, at the back of the mind, this woman could have been pregnant. So we did a small study in my country. We called it a missed period study. And this happened in the midst of request for emergency contraception. So these women who come to you and they say they wanted a period back, or some of you will even tell you lies, hoping that you give them a drug for as an emergency contraception. So it was in the midst of such requests that we wanted to see whether we could roll out the use of this mifepristone as a treatment for the missed period. So we called it a missed period study. So we explored implementation of safe contraceptive in the midst of requests for emergency contraception. So we had an eligibility criteria. I've defined for you missed period, what it is, and we offered a single dose of 50 milligrams, and we classified these people based on when the duration of the missed period, 1 week, 2 weeks, and up to 3 weeks. And of course, as I indicated, we deliberately wanted to follow what nature does, that some women may not afford a pregnancy test, but were able to do a pelvic exam. And we requested them to come after a week. And this was way back, it's now almost 5 years ago. We did this study in a various site just to have a flavor of each in the tertiary hospitals, first-level hospitals, rural health centers, and urban centers. And just some of the variables that we had 250 women take place in the study. As you can see, the main age group there, most were 25 to 29. And the sexual debut, the mean was 18. And the majority of the gestational ages from the LMP were 6 weeks. And most of them were actually educated. That's why they were ready to tell us lies. So, we also inquired in the previous pregnancies whether they were planned or unplanned. So you can see that 150 of them actually the pregnancy was unplanned, and 40% got pregnant previously because of issues related to use of contraceptive, maybe wrongly. And out of the 250, after the 1 week review, 240 of them, or 96%, had resumed their periods. And we also graded and inquired with regard to satisfaction. All the women reported satisfaction with the method with no side effects. And so our conclusion was that in women seeking help and measures contraception and termination of pregnancy, we recommended that we scale up the use of mifepristone as a contraceptive in Zambia. Again, it is well known that mifepristone, along with other hormonal, hormonal tablets, in a single high dose, soon after unprotected sex or non-persistent good use of regular contraception, it can prevent pregnancy by delaying ovulation or stopping the fertilized egg from attaching to the uterus. Now, out of interest, again, a team in Europe wanted to develop a monthly single dose, or a weekly single dose contraception using 50 milligrams of mifepristone. Now, previous small studies had actually shown the benefits of these women taking a weekly dosage of mifepristone, even in monthly. For the monthly, they said if the menstrual cycle is less than 28 days, if somebody took the mifepristone on day 18, they would actually use it as a contraception. Above 28 days cycle, they could take it on day 19 or day 20. So these people were actually inquisitive, that in this study that they recruited almost 560 women, there was quite a high number of unexpected positive pregnancy tests, and also a number of them developed ectopic pregnancies. So they are actually still analyzing the data. The study was stopped in June on the 17th because of these findings. So the data is still being cleaned up. But the confusion, as I said, smaller studies had found benefits, but this bigger study did not. So in one way, they are also recommending that maybe more longitudinal studies should be repeated before somebody can recommend the use of this weekly or monthly contraceptives. There are some of my colleagues in Zambia who have been using the weekly mifepristone. They've not reported any pregnancy. I think in total they could have followed up almost 250 women. So it's an interesting area of research that maybe some of us could develop interest in. Okay, so that I was just showing that picture of when to take in relation to the length of the cycle. So in conclusion, mifepristone is a fairly safe drug. It is of clinical importance in a lot of reproductive health care. There is call for ongoing research, access improvement, and we can also consider it in our clinical practice for some of the conditions that I've addressed. Thank you very much for listening.
Thank you very much, Prof, for a very informative session. Our next session is about updates on global and regional abortion policy. And allow me to welcome Dr. Abraham Fesehai Siyum from Ethiopia. He's an associate professor of OBGYN at St. Paul's Millennium Medical College with a very strong academic and research background in women's reproductive health. Welcome. Round of applause to him. while we are waiting for this presentation, I would like to remind everyone to fill in the attendance list, because if we don't fill it, we will not get our certificate. Please remember to do it. They have been shared a QR code when we were in the main hall. No, for the first time. It's once for today. Yeah.
Okay. Thank you very much for the kind introduction. And I'm sorry for the technical issue with uploading the PowerPoint. So without wasting much more time, I would like to directly proceed my presentation. So we are going to quickly look at the global and regional abortion policy, and along the way we'll see the recent updates in the abortion policy. So these are the contents of my presentation. So we'll be talking a lot about colors. They are not just only colors. The colors mark whether a woman will access safe abortion on time, depending on where she is located, irrespective of what indication she has. So we'll try to see what these colors designate regarding abortion policy. So in the introduction, as we can see that unsafe abortion is still a major public health problem, one of the top causes of maternal mortality, and specifically in our region, Sub-Saharan Africa, it presents a burden because we do have one of the highest maternal mortality in general, but when we see it in terms of unsafe abortion, we are the ones who carry the highest burden in terms of morbidity and mortality, and strong evidence shows that the case fatality rate of unsafe abortion in sub-Saharan setting is higher than in any geographic location within the world. Apart from that one, around 23% among around 23 abortion-related hospital severe hemorrhage, 9% have a near-miss event, and there is 1.5% maternal mortality, or 1.5% in deaths. So why is it important to understand global and regional abortion policy as it currently stands along with the updates? So one, enabling regulatory and policy environment is needed for a woman to access safe abortion whenever she is legally eligible, depending on where she is located. Again, it's not just only the abortion policy. The other regulatory health and the delivery requirements also remain codified within the abortion policy. And the other main reason is differences in abortion policies throughout the world affect women when it comes to access to safe abortion. Being in one geographical location where safe abortion is allowed makes a woman eligible to safe abortion, but at the same time, many women, because of lack of or restrictive abortion policy in their geographical location, they cannot still access safe abortion, and they resort to unsafe abortion, and eventually the complications arrive, and that's why our Sub-Saharan Africa also carries one of the highest burdens of unsafe abortion. And the other thing is policy is associated with maternal and with worse maternal and perinatal health outcomes, and at this time we do have strong evidence that shows reforming abortion from more restrictive to more legal or more liberal abortion policy improves maternal mortality, and it improves also the fertility rate. So I'm going to display two big countries that could stand as an example when it comes to the benefits of reforming abortion from more restrictive to more liberal. So in our region of sub-Saharan Africa, and in general in Africa, Ethiopia is considered as one of champions of reproductive health in terms of access to safe abortion and unsafe abortion-related maternal mortality and morbidity. So as you can see here, prior to 2005, which is a landmark year where safe abortion policy or abortion law policy was reformed in Ethiopia from more restrictive to more liberal, depending on 5 circumstances. So before that time, maternal mortality from unsafe abortion was very high. Abortion-related death was like the #1 leading. It was not PPH, it was not hypertension. But a decade later, after the abortion policy reforms, maternal mortality from unsafe abortion has significantly decreased in Ethiopia. It is less than 10%, and the recent data that we have is less than 6%. And this shows that this can serve as a best example when it comes to changing abortion law policy from more restrictive to more liberal in our region and in other developing countries. And then I'm going to take you the ES, but with a different perspective, because for a long time, abortion law policy in ES has been one of the exemplaries. And we do have a very strong data from different states that have demonstrated changing the abortion law policy from more restrictive to liberal improves maternal mortality as well as infant mortality. But what has recently happened in the US have had a reverse effect on it, as we all understand, in 2022, along with the release of the WHO guidelines, which also recommended for the first time on abortion decriminalization. The US abortion policy was overturned. So after a few years, there is one paper try to see on what has happened, not in terms of maternal mortality, but in terms of infant deaths, because the babies or the fetuses that have had severe congenital anomalies due to more abortion restrictive laws within the states, women were not able to access, and as a result of delivery, the babies had severe morbidity, and the perinatal or infant mortality have increased by 7%. And there is also one other study that have clearly showed that in the states where there is more abortion restrictive, there is higher maternal mortality compared to those that have more liberal abortion policy. So what are the factors that shape abortion policy? The #1 is evidence, of course. One is to guide clinical recommendations, but at the same time also evidence-based advocacy, because advocacy is also the other main factor that can affect abortion policy. The other biggest landmark in abortion policy is the 1994 ICPD conference in Cairo, in which more than 150 countries have adopted the concept of reproductive health to see reproductive health as a separate entity and act on relaxing or improving their abortion policies. And then we'll see how many countries have had changed their abortion policy as a result of that, nearly 3 decades after that landmark conference. And the other ongoing agenda that we have is SDGs, because access to safe abortion and contraception is embedded with those SDGs. And the other factor that affects is pro-choice activism, which are the green waves that has been the main force to change abortion policy from more restrictive to more liberal, mainly American countries. We'll see them in detail. Of course, anti-choice movements are there. Religion, pandemics, that is COVID-19. So if we see the global achievements after ICP 94, because that's for SRH in general and specifically for abortion policy. So this is not just statistics. 34% or 662 million women of reproductive age, they live in 77 countries, where abortion is allowed on request. And we do have another 23% where abortion is allowed on other social and economic grounds. Rwanda and Zambia and Ethiopia are also within this category. And we have another 12% where abortion is allowed only for women's health, and then around 6% they live in 21 countries where abortion is totally banned. So if we see the result of the initiatives or the adoption of reproductive health concepts following that and improving the abortion law policy within countries, as a result of that, around the maternal mortality from unsafe abortion has decreased by 42% between 1994 and 2014. So these are the colors that we see. I will come to the details later, but in general, green represents safe abortion on request, and the blue, where Rwanda is categorized, it allows for broader socio-economic backgrounds. But it doesn't mean that the access or eligibility for abortion, incest and rape is embedded in most of these yellow and also light red ones. So if we see how many countries have changed their abortion policy as a landmark of the ICTP in Cairo, there are in total 40 countries. As you can see, at least 10 countries have gone from category 1 abortion policy to category 3. And we do have 5 countries which were from category 3 to category 5, which is abortion indication based on the mother's request or maternal request. So the other major achievement that we have post-ICPT is the recent quality abortion care guidelines released by WHO, in which I participate also in the active participation, in active dissemination of the evidence, as well as in writing the handbook that adopted most of the recommendations for easier clinical guidance for mid-level and low-level health providers. And more recently, so these are the contents of recommendation on our abortion policy on the new WHO guidelines. As you can see, one is decriminalization of abortion. The other one is ground-based approaches, gestational age limit. In total, there are 7, but these are the most important ones. And recently, in May of this year, we do have another guideline release, which guides countries on how to draft, implement, and then also review abortion policy. So that is also another strong evidence-based recommendations which can guide countries that still have more abortion restrictive policy. So you can see it has 4 contents: understanding, designing, implementing, and then reviewing the new abortion policy. So if we see the global and regional abortion policy as it currently stands by region, I will start from the classification first. Category 5 is green, which means based on it is available on request. Category 1 is totally banned. Category 3, where Rwanda is categorized, it permits for category 4, it permits for social and economic grounds. And category 3 is, in addition to saving the woman, it allows also for health reasons. So we'll start with the US, because what goes in the US, it comes around in the rest of the world, at least as shock waves. And we have felt it recently. I think we all agree on that one. So if we see the states, 11 states are in the, they do allow access or say based on request, and we have 11 states where abortion is protected under the law, and 14 states, they have, including some of the states like Albania, it is completely banned to have safe abortion care. And if we come to Africa, as you can see, 3 countries are in the blue category, Ethiopia, Rwanda, and Zambia, because now we are in Rwanda. I would like to start from that one. And we do have 8 countries in the green category, and we do have 6 countries where abortion is prohibited. These are Egypt, Madagascar, and Senegal, and Sierra Leone. There was a recent bill passed in Sierra Leone, which was a major shockwave as an achievement when it comes to improvement of abortion policy. But apart from signing the bill, there is no any change on the ground. Still, safe abortion care is not practiced in Sierra Leone apart from post-abortion care. So that's why I put it as it currently stands. So if we see in Europe, 40 countries, they allow it based on maternal request. 2 countries, they allow it on social and economic grounds. And there are also 5 countries that doesn't allow abortion. However, still there is a variation within those countries. For example, in Italy, there is a variation in consensus objection. Higher percentage of physicians, they refuse to provide abortion despite being in the green category. So having an abortion policy as a standalone intervention is not enough. Behind the curtains, people have to work when it comes to actually implementing the law. So when we see to the South America, I think this is a region that have major strides during the COVID and immediate post-COVID. At least 3 countries have improved their abortion policy, mainly Uruguay, Argentina, and Colombia, the last one in 2022. So when we see in Asia, at least 2 of the biggest population, China and India, one of them is in the blue zone and the other one is in the green zone, which means majority of the people, population, women in the reproductive health, if you see it as a region, they can access safe abortion for broader indications. But there are 3 countries that completely ban abortion altogether, Philippines and Iraq. So if you see Canada and Australia, Canada general access to safe abortion. Abortion is like the other procedures. In addition to that one, the main drug for or abortion pills are covered in the insurance. And abortion law policy in Canada has been almost stable for decades, unlike that in the US, which have varied in the last 3 or 4 decades, depending on who controls the government. In Australia, in general, safe abortion care is allowed up to 24 weeks, but still there is also variety within the states. So what are the current challenges that abortion policy in general is facing at global and regional level? So the first and number one is the rapid and unpredictable political landscape, mainly the overturn of abortion policy in the US. Second, withdrawal of US from WHO, which I call a major setback with clouds of cinema impact, because we don't know the impact. The impact is going to be felt down the coming years or decade, because as US is the main funder or was the main sponsor of WHO. And the other one is contracted funding. Again, the US gag rule, US aid, NIH defunding, and this all happened when we were recovering from the post-COVID, from the impact of the COVID. And the other problem that we have is conflicts and the COPs following the COVID. And then, of course, infodemics. This is where the anti-choice or anti-abortion movements use like low quality evidence to challenge major existing or strong evidence to advocate against abortion. The other challenge that we have is also climate change. So I would like to say a few words on what we can do as a region to address some of the major challenges that we are facing. One is, I think countries in our region has to come together how they can support each other. And one of them is the South-to-South collaboration, which has been effectively implemented between Ethiopia and Rwanda, and now between Ethiopia and EXACOG. I think Professor Bolika is here. He can be a live witness for the South-to-South collaboration, how it is improving the understanding of SRH in general, safe abortion care, and the importance of access, including relaxing the law. And the other thing is governments, they should come to increase the expenditure on essential health care, one of which is safe abortion care and contraception. And the other major challenge that we have is, of course, climate change. So, and for this one, I think as a region, we can use certain interventions that can allow people to access safe abortion care. For example, self-management of abortion care, because once these people migrate because of the climate change, they cannot find qualified or specialized physicians and providers on time. So we have seen it in Ethiopia, in certain regions where there was a climate change, and self-management of abortion is one of the effective intervention. And the other thing is task sharing, like training midwives and the nurses, so that they can largely reach to the populations who cannot access physicians or specialists. So this is the end of my presentation. Thank you very much.
Thank you very much. Our next session is a neuro abstract. We are going to welcome Dr. Charles Nkurunziza, who will talk about risk-based cervical CS screening tool in low research settings. Please welcome Dr. Charles Nkurunziza. He's a gynecologist from University of Rwanda, and he has research focused on cervical CS screening and early detection in Rwanda. Please, a round of applause for him as he's sitting up.
So meanwhile, as they get the presentation ready, I understand there are some people who could have had points to raise, insights to share, or maybe questions about the previous two presentations. One about abortion policies and mifepristone. So I think we are trying to rush because of time, but at the end of his presentation, I think in addition to the Q&A session for his abstract presentation, we can as well receive very few questions, 1 or 2 from you, the audience, about the previous 2 presentations. Thank you.
So, thank you. Thank you so much. It's a pleasure to be here sharing findings from our research. It's a research that is entitled Risk-Based Cervical Cancer Screening Tool in Low Resource Settings. It was a cross-sectional study with prospective participants recruitment. So as said, by name of Dr. Charles Nkurunziza. I was obstetrics and gynecologist at University Teaching Hospital of Butare. I was with, the study was conducted with my colleagues that work together at CHUB. So, as it was said in the previous presentation about gynecological cancers, cervical cancer is a global burden, it's a global public health concern, and unfortunately more than 90% of deaths due to cervical cancer happen in the low and middle income countries where also Rwanda belongs. And as it was also said, cervical cancer is a preventable and curable disease or gynecological cancer if with adequate screening and timely detection and management. And where screening is appropriately done, cervical cancer has become rare. So as I said, unfortunately, in resource-limited settings, screening, which is one of the pillars in preventing cervical cancer, the rates for screening uptake is critically low in the low and middle income countries. In Rwanda, its current estimates are at around 35%, and we have different individual and systemic factors that contribute to that low screening uptake. And we thought that a risk-based women triage might enhance screening uptake in resource-limited settings. So our objective was to develop and evaluate a cervical cancer risk scoring tool that for low resource settings. And so our specific objective was to develop the tool and then evaluate its performance. So we did a cross-sectional study with prospective participants recruitment. The study was done at the University Teaching Hospital of Butare. It was done from January 2025 to December 2025. And our target population was non-pregnant women 30 years old and above who were attending GIO outpatient services. So our sample size was estimated at 417 participants. We got ethical clearance, and so we collected data on different known risk factors, and also if presence or not of symptoms, though not specific, symptoms are not specific. Participants in the study were screened using VIA, and the results were recorded as either positive or negative. Data analysis was done with spaces. So bivariate and multivariate analysis was done. So beta coefficient of significant variables and also clinically relevant variables were used to establish a risk scoring tool. And then participants were assigned a score using that tool that was developed. And narrow C curve analysis was done to determine the tool performance. The Uden index was used to determine the optimal cutoff value for the score. As a result, as I said, the sample size of 417 was achieved. Just for some statistics, participants over the age of 40 years were 74.1%. Majority did not have two primary education, about 68%. About 15.6% had their first sexual activity at less than 18 years. First delivery at less than 19 years was at around 6%. Those participants who had 5 or more deliveries were about 38.4%. In our study population, our HIV prevalence, HIV positive, was 10.3%. Among participants, those who did not have prior cervical cancer screening before our study were at 65%. So a positive screening meant either the participant has a VIA positive or she had presence of clinical features of invasive cancer. So having either a positive VIA or presence of clinical features, those who screened positive were 13.7%. And those who has the features of invasive cancer, that was clinical diagnosis, were at 12.2%. Those who have symptoms, just don't know, though they are not specific, they were at 44.2%. After doing a bivariate analysis, we found that most of the assessed variables had an association with a positive screening. And those variables included the age, the education level, age at the first sexual activity, age at the first delivery, HIV status. So most of the variables that we studied had an association. So when we did the logistic regression analysis, we found that 3 variables had an independent association with a positive screening, which were number of full-term deliveries, a prior cervical cancer screening status, and the presence of symptoms. With the beta coefficient of those statistically significant variables, and also the variables that were not significant in our study but clinically relevant, we used those who were not significant in our study but clinically relevant, we assigned them a beta coefficient of 1. Then all the coefficients were multiplied by a constant of 2, then rounded to the nearest integers, because we need to develop an integer-based scoring system. So that is after that is the tool that we got, which had the variables. We had education level, at first sexual intercourse, number of full-term deliveries, HIV status, and the prior cervical cancer screening and the presence of symptoms. The total score was scored at, the maximum score was 19. And when we applied this developed tool to our study population, we found that the minimum total score was 2, the maximum was 19 with a mean score of 10.2. We did an RSOG curve analysis, which found an area under the curve of 0.84 with a p-value of less than 0.001. And the maximum index was observed at a cutoff score of 12.5, but for the purpose of of minimizing missing high-risk cases, we prioritized sensitivity, and we selected the cutoff of 11.5, which was around 212. And as the result, we found that a total score of less than 12 was low risk for positive screening, and 12 and above was high risk for positive screening. So our study findings, as a discussion, our study findings, we found that most of the variables we studied were more or less similar. The findings were similar to other studies done in our country and even in the region with similar settings. Particular points were on HIV prevalence, which was higher in our study, 10.3%, while in general in Rwanda, the prevalence is estimated at 3%. And it could be explained by the hospital-based nature of our study, because we most likely received the high-risk patient that had consulted the hospital. There was also a high prevalence of clinical cervical cancer, which was also different from other study done previously, which is also could be explained by the hospital-based nature of the study, because we're receiving high-risk patient coming to the hospital. We thought that a community-based prevalence study would generate a more generalizable prevalence. Prior positive screening for cervical cancer ideally would be protective for cervical cancer, but in our study, a prior positive screening was associated with positive screening in our study, which also might be explained by the fact that we were receiving a patient. The study was done in a referral settings, where we were receiving people from lower level facilities, and the study did not capture the time from their prior screening to our study screening, which could explain why prior positive screening was associated with positive screening in our study. So the tool that we developed in our study developed a good discriminatory ability to predict a positive outcome, and different cervical cancer risk prediction models. They were developed in other different settings, especially in high-income settings, which are different from Rwanda and the region. And also, to the best of our knowledge, so far there is no externally validated risk prediction model that is recommended for universal implementation, which is the gap that we wanted to address in our settings. So the study had limitation because, as I said, there were risk for bias, like for participant selection, because the study was based in the hospital settings, and the patient selection could be biased because in our referral settings we most likely have high risk patients. There was also a risk for recall bias, because for the risk factors we relied on patient self-reported history, and also the screening method used, which is the VIA screening method, which is a subjective method, may also have introduced observer bias in the participants' classification as positive or negative. So our recommendation is that this tool has demonstrated the good discriminatory ability for prediction of positive screening outcome. It is a short and easy, and can be used with no requirement of special skills. It can be useful in triaging women at the community level, which can enhance cervical screening service uptake. But we recommend external validation before the tool can be used in the routine. So those are the acknowledgements. and some of the references, which brings us to the end of the presentation. Thank you for your kind attention.
Thank you very much, Dr. Shah. For those who have questions, this is your time. You will talk about your question and to whom you are addressing it. Thank you.
Thank you very much. I have just a small question for the previous presenter who presented on abortion. Yes. You said about providing safe abortion for socio-economic reason. And Ethiopia, Rwanda, and Zambia were put it together. So can you explain more about those socio-economic reasons? Thank you.
Okay. Thank you. So when we say socio-economic issues, it means the woman who is pregnant doesn't have enough economic and social support to carry the pregnancy to delivery and also to take care to raise the child after delivery. So it is very individualized, but you cannot have a uniform definition for all women because the degree of support, economic and social support that a specific woman needs could vary from where she is located and where she lives, with whom she lives. So it is up to the provider because with each abortion policy, there is also regulations how it should be implemented. And we find the implications not directly within the abortion law, but within guidelines which further mentions or explains what do we mean by socio-economic problems or indications. So the ones who are drafting the guidelines within each country might define it very well, or they might make it specific to each country. But when we say socio-economic grounds, in general, it means the woman is not ready to carry the pregnancy till delivery and take care of everything that comes after delivery. Thank you.
Thank you very much.
Yeah, thank you very much. I also have a question on the mifepristone. As I heard during the presentation, they said that it's a medication that it can be used even to restore menses. I was asking myself if it is being used in Zambia. Is it really for over-the-counter medication like paracetamol, so that because it has been adopted for that reason of socioeconomic, and I would like if it doesn't require this special prescription for a specialized medical doctor to be prescribed, if it is a social issue, it should be like very easily accessible at any pharmacy without prescription. Thank you very much. That was my question.
Okay, thank you very much. That's a very brilliant question. Whether it's given or sold without prescription, whether it has a legal basis. So mifepristone is registered for medical termination of pregnancy, but then it is freely available on the market. So it's not for me to comment, because if it's meant for the termination of pregnancy, we follow the law, which requires that 3 doctors in good faith should say that this pregnancy should be terminated. And the clause, as we just heard, the commonest clause refers to the mental and physical health of the woman. But when we are using it for this, the way they use contraceptive, it's not considered as a termination. I don't know whether I've answered you, but we can chat on the side.
maybe to add that in some countries, termination of pregnancy is called menstrual regulation rather than being called they have protocols where it is clearly called national guideline for menstrual regulation rather than being called termination of pregnancy. So when you present or when you fall on a presentation where they say menstrual regulation, it may sound like mifepristone is being used for menses, but it's a way of protecting the reproductive rights for people can access abortion care services more freely over the already labeled and debated terms abortion, termination of pregnancy. Thank you.
Yeah, thank you very much. Back for my presenter, I'm Dr. Eric, working for Save the Children, especially in my Italian setting, Mahama refugee camp. The reason why I was asking this question, I know that we always are close on cases like gender-based violence. They are having also this risk of getting unwanted pregnancy. I was also just wanted to request like an advocacy to come to invite you if possible. We know that we are now in a crisis of fund cuts. If possible, we be happy to receive you in the Mahama camp so that you can at least give such presentation and the new adaptation for this new protocol. To my point of view, it will be very important and very useful for the humanitarian setting, especially in the refugee camp. Thank you very much. That was my opinion.
Thank you. Do you have other questions?
Thank you so much. Thank you so much. So I think even I have the mic. So my question, I'm Blaise, I'm a gynecologist. I wanted to ask Dr. Charles about that risk scoring screening model, whether the participants were later tested with a screening test, a high performance screening test, either HPV, DNA screening, or pap smear. And another one is what is his proposition about the validation of this screening tool? What do you think we can, or how do you plan to scale it up and validate it fully for trial of implementation? Thank you.
Thank you so much for your great question. About if the participants were further screened with a higher performance test, as I said, the tool is designed for low resource settings, so that's why we used an easily available screening test, which is VIA, in our settings. And so for those who screened positive, they were channeled in the usual care pathway. Those who needed the colposcopy, they were channeled for colposcopy. Those who needed the biopsy, they were just followed up in the usual care pathway. But the screening test that we used for our study was just VIA screening, and the further care was just the usual care pathway. That's where the participants were channeled when they screened positive. So about further steps in the validation of the study, so we, as you saw, it was done in a single facility, and as I said, hospital-based, we are more likely to capture high-risk participants. That's why we aim at validating the study, the tool with other facilities, and ideally with a community-based study where we can try to validate the study in the real settings, not in the hospital or health facility settings, but at the community level. But because that's where also we aim to use the tool, because our objective was like the tool that can be used at the community level to screen, to triage women and convince them for screening, because we have an issue with screening uptake. Don't know if I answered your question. Thank you.
So, actually, I wanted to know, because you said those who had scored less than 12, they were low risk, and those who had 12 and above, they were considered high risk. I was wondering if, like, we use that tool, someone scores less than 12, can we just hold her and say that she's low risk to have precancerous lesion? Then we advise her not to do screening.
Yeah, thank you.
Because to validate it, I think it will need a high performance test. Thank you.
Yeah, thank you again for your insights. Those who score less than 12 and we call them low risk, it does not mean that they don't need screening. But the objective of the tool is to address the issue that we have of low screening uptake. We thought that if we tell a woman that, so we should be telling every woman to go for screening actually. But then we know that screening programs are already there, but we ask ourselves why people are not attending those services, because we know they are there and they are working. Then we want to see if we can at least triage women. Those who are at high risk, we focus on them. We focus on them so that they can go for the screening. But also we do not leave behind those who screen the low risk, telling them that it does not mean that they're 100% free from developing cervical cancer, but at least focusing on those that screen the high risk and following them till we have them attending the screening services. That was the main aim of having the tool. Thank you.
Let us welcome the last question for today.
Thank you so much for the presentation. I wanted to address my question to the professor who presented on the different forms of cancers. Many times people say that cancer is a silent killer. I want to know to prevent against cancer unless diagnostic to the doctors. Thank you. Any strategy to prevent, to know that people have cancer? Because you talked about different forms of cancer. And I don't know if people can know if they have it unless doing a diagnostic. Thank you.
All right, thank you. I get the question clearly now. In fact, when patients come to us, they have complaints. That is where we build it up from. And the complaints that they give us will also help us know whether we need to go further into the history that they are giving to us. So I'll give you a typical example. This is a 52-year-old woman, has come in and she says, these days it looks like she's spotting. Previously she was having her normal menses. These days, just a spot, and then she doesn't see anything again. Looking at her age, and also looking at when women in that setting will be in the menopause, then I know she's in the perimenopausal area. In which case, now my questions will be direct. We call it direct questions. I'm going to find out how this bleeding starts. I'm going to find out whether this bleeding is provoked Unlike a 20-year-old who had come with the same complaints, I'm not going to be asking whether the bleeding is provoked or not. But my questions will be directing me as to finding out what type of condition she has before I'll even examine. And before I examine her, I already have what we call differential diagnosis. I have 2 or 3. When I'm examining, I'm going to reduce these differentials into maybe 1 or 2. So for this particular patient, what it means is that after taking this comprehensive history, also finding out more about her drug history, what are you taking? Is it something that could also cause this type of bleeding? Then I move on to examine. I wouldn't let this patient leave my consulting room without examining her, what we call the pelvic examination. It first starts with C. Look at whether there's something there and feel whether you can have something. This is going to improve on which condition I suspect she has. I look and I see something. If there's a mass, as I mentioned, every mass we must say is cancer or we can leave it. Around that age, everything I see, if there's something on the surface, I'm going to biopsy it. I'm going to wait for histology, and I'm going to treat based on the report. So these are strategies which are embedded in the training from medical school. And it's also embedded in the field that you are, especially when it comes to gynae oncology. There are several things that the general gynecologist will not do. But when you come to us, we know what should go into. These are the strategies that we put in. And we also do this advocacy and also do continuing professional development, training, workshops, letting people know if you have this patient, look for 1, 2, 3, 4. If you don't understand, then refer. Thank you.
Thank you very much, Prof. As we are coming at the end of this session, Dr. Francis, do you have any take-home message for us?
And the last one. It will be the last one. After this, I hope for someone who has something else to say, will bear with us and say it tomorrow, because there is tomorrow also. So for the sake of time, I want to everyone in here to really appreciate yourself for the patience you had. Thank you. So in a bit of a summary for today, we must note that we really had an opening and first day session for the conference, and we highlighted a few, which is not the most important, but this is at least what caught our attention, especially when the RSOG president mentioned about highlighting the importance of modern technology and innovation. This is where we're headed, like placing women at the center of development, which is embedded in the theme of this year's conference. Strengthening women, strengthening quality women health, continuing professional development, and the research and collaborations. These are the things that we keep listening to and sometimes take for granted, but this is what we come to school, and this is why we practice, and this is what is expected of us as trainees and trainers. So without wasting your time, I have to mention something else that came from the UNFP representative, where he mentioned the need to assimilate all it takes to combat preventable causes of maternal death, and the effort to bring UNFP FIGO partnerships to the interests of national societies, not just for the names, but to bring them to the interests of nations. So, and the last bit will be the willingness of UNFP and the World Health Organizations to foster maternal and child health through partnerships with our Rwandan Society of Obstetricians and Gynecologists, and the extensive continued support of the Ministry of Health, especially in the support for the quality resident training programs. And then about FIGO. If you listened with the ears of like mine, we must have had funding several times. If the funding that was said today is implemented, then we are headed for much better tracks. So, and in this breakout room, I cannot forget to note that we really had an eye-opener about the status of malignancies. Really, we did. So we had much more than what we get from our seminars, from our daily teachings and presentations, but today it was like an eye-opener. It's more of, it's problematic, more than the name really sounds. It's not just cancer, it is a global problem, and for Rwanda in particular, we must note that we are not to the ground where we used to be. We are on the right track, as we must have heard from the prof who presented, Katena, yeah. I think I mentioned her name right. So for today, this is where we cross, and tomorrow there will be no more introductions because at least we know one another now. So there will be no Indinzi troops dancing. There will be many things that happened today will not repeat themselves at least, which means we will be more engaged in really rich conversations. So see you tomorrow. I hope tomorrow we keep time. We start 8:30. That is starting time, not arrival. Thank you. Have a good evening. God bless you all.
I was just focusing on abortion.